Good afternoon, everybody, and welcome to our 28th iGeriCare live event. We're lucky, as usual, to have geriatrician and co-founder of iGeriCare, Dr. Richard Stramko, joining us from St. Peter's, Hamilton Health Sciences, McMaster University. Today is August 19th, 2021, and today's topic for our live online event is young-onset dementia. This is a topic that has, I think, become increasingly important over the last decade as people have begun to realize that some of the programs, services, and issues for older adults with dementias and their caregivers are quite different from people who might have a younger age of onset for their dementia. And just terminology wise, we're using the term young onset dementia. You will sometimes hear people use the term early onset dementia, or even in some centers, they talk about working age dementia. But the term early onset dementia is sometimes confused with early stage dementia. So we'll use the term young onset dementia. And by that, we're referring to people who may have dementia symptoms starting before the age of 65. And young onset dementia accounts for anywhere from 2 to 8% of all dementias. It's probably a bit higher because it's probably underdiagnosed in younger adults as well. So during this live event, we'll talk a little bit with Richard about young onset dementia, what it is, how it may affect younger people, the possible causes, and some of the implications. So welcome, Richard. Great to see you again.
Hi, great to see you as well, Anthony.
So why don't we just start off, as I said, from a terminology standpoint, young onset dementia we use to refer to people with dementia symptoms before the age of 65. What else can you say about the definition or young onset dementia in terms of what you see in your practice and other issues, causes?
Yeah, absolutely. So the definition is the same in terms of having progressive cognitive impairment, having objective testing deficits, and having functional impairments day to day. It's just happening before the age of 65. And, it can be quite shocking for people as well, because cognitive impairment is somewhat more accepted or less stigmatized in older adults sometimes, and less surprising because that's what people are used to seeing. But when it impacts people in their 40s and 50s and starts really robbing them of those prime years of their life, then it can be quite disconcerting. And there's no great frame of reference for those people. It's something that's completely shocking and unexpected. So the same diseases can cause early on or young onset dementia. So Alzheimer's disease and vascular dementia and Lewy body dementia, just changes in the relative percentages of the cause. So whereas Alzheimer's disease may be the large majority of usual age of onset dementia, it will be a lower proportion, and there are slightly different causes of early onset dementia as well. So you deal with the typical characters, but you also have to think about additional conditions as well. So we think a lot about thyroid disorders or problems with metabolism, but there are also other inflammatory conditions or slightly different or more rare neurodegenerative conditions that we have to consider as well as various other infections such as HIV or syphilis. So there's just a bit of a shifting in terms of the causes. Some are a little bit more common when you get into the early onset or young onset. I'm gonna have to correct myself like 5 times, or 6 times.
And I think that does reflect, the use of both terms is relatively common. And I think one of the other things that is probably worth mentioning is that we have seen more cases of cognitive impairment related to COVID-19 as well. So when we think of infectious causes, that is probably going to be one of the other sort of newer emerging causes to think of in terms of infectious diseases. But I think you've highlighted, and we will talk a little bit more about some of the different causes. Again, Alzheimer's disease is the most common cause of dementia, but there are many other conditions that can cause dementia. And age is still one of the biggest risk factors. So as you mentioned, it can sometimes be a bit of a shock, a surprise when a younger person is diagnosed with dementia. And I think we'll talk a little bit about some of the challenges actually getting a diagnosis, because I think many clinicians are not necessarily thinking dementia when a younger person is presenting. And then as we've talked about, and in some of our online lessons around, what is dementia, the importance of doing a thorough medical investigation to make sure there is not a reversible cause of cognitive impairment that looks like a progressive dementia, looking for infections or vitamin B12 deficiency or thyroid deficiency, some of the other causes that we do talk about in the lesson that may present with cognitive impairment, depression, another example, but are not necessarily due to a progressive dementia. And I guess in your experience and in your practice, what are some of the other key issues that people with young onset dementia may face that are perhaps different from those who are diagnosed later in life?
I think one of the biggest things is that when you're diagnosed later in life, oftentimes the people that you live with or many of your caregivers perhaps are in the retirement age. And so they actually have a reasonable amount of time to spend attending to caregiving. But if you're in your 50s or 40s and you still have children in school and your partner is still working full time, that gets to be very challenging. So if you're an older person and you only need, let's say, a personal support worker to come in twice a day to check in and see how you're doing, then that's fine. But if nobody's around and cannot provide additional resources, it can be quite stressful. And then also there's the stress of raising children, and then you essentially you have somebody else to care for instead of your partner being able to provide help in raising the children. Now it's like you have another person to care for. So especially for the caregivers at that stage, it can be very, very challenging. And then also the supports, as you alluded to earlier, are kind of built. The peer groups that you'll see of people that have cognitive impairment are more likely to be older. And sometimes you want to relate to people that are at the same stage or kind of having similar experiences to the ones that you're having. Whereas when you're in that young onset phase, it's harder to find people to relate to because it is more rare. So, you were saying it's less than 10% of all dementias. So it's quite a small number.
But I think the other thing to keep in mind is, we do talk about in our stages of dementia lesson that, dementia does lower life expectancy, but there are a lot of factors related to that. And somebody who is diagnosed at a younger age is more likely to be living longer with dementia. Somebody who is diagnosed at a later age may be more likely to have other medical conditions, whereas somebody diagnosed in their 30s, 40s, or 50s may be much more likely to be otherwise physically healthy. So, it's important for people to also make plans about, potentially many years of living and managing with dementia for both the caregivers of somebody with young onset dementia, but also somebody living with it. They need to consider that they will be living many years potentially with, and how will they manage their condition from that standpoint. So I guess with respect to young onset dementia, Walk us through whether there are any major differences, I guess, between how dementia may affect young people or the types. You did mention that there might be maybe a slightly different types of disorders, maybe some rarer disorders. But are there other things to consider in terms of some of the differences that may be important between a younger onset of dementia?
Sure. In some cases, they may present just as they would in older adults. And when that happens, and the history in terms of, let's say, Alzheimer's disease and having poor short-term memory, and it progresses exactly the way you'd expect, then it's fairly easy to kind of narrow in on that diagnosis. But sometimes some of the, let's say, language problems or visual spatial issues that we talked about in previous lessons and live events, those are more predominant, or those could be the first complaint. So somebody could be stuttering with their speech or have word finding difficulty. They may have challenges finding or navigating through certain spaces, or have depth perception issues. They may be the first presenting complaints, as opposed to just a memory kind of slow progressive issue. That people are more likely to have genetic causes as well. So we've mentioned in other live events the amyloid precursor protein, presenilin 1 and presenilin 2. And oftentimes people will have a bit more aggressive course in those situations or have associated symptoms. Sometimes people may have seizures, and that can happen. The onset of those can happen in people's 30s, 40s, and 50s. So that's quite young. And you'll see a strong family history usually in people that have those issues. In vascular dementia, we've talked about the many different causes there. There are some genetic causes, one called CADASIL. And again, you'll get slightly different symptoms. It's not just a slow progressive decline or a stepwise decline. People may get headaches and migraines and seizures. So you're starting to see this theme where it's like, there's some additional feature that may be present, or it might be slightly more aggressive. And behavioral variant frontotemporal dementia is much more common in the younger age range. And instead of having a cognitive predominant presentation, with memory and thinking, it's a change in personality and change in behavior. So it's just a slightly different flavor in that sense. And then you're worried about, because autoimmune conditions or infections are a bit more likely to be happening in that age range as well. And there are a few other neurodegenerative conditions. So something like Huntington's disease, which is also a genetic disease, is more prominent as well. So you're in conditions that are associated with movement disorders. So we've kind of described some of the Parkinsonian dementias as well associated, but there are things like progressive supranuclear palsy and corticobasilar syndrome, where people will have slightly atypical presentations of Parkinson's-like illness. Those are more common in younger individuals as well. So you're starting to get a bit of a different flair.
It's often the case, we think of many of these conditions as quite rare, but actually when you add up all of the various rare causes, they're actually kind of substantial. It's just sometimes really challenging to get a diagnosis. And I think that can be really frustrating for people who are living with the symptoms and their care partners when they know something is wrong, but it may be challenging to get a definitive diagnosis. And I think what you're saying as well, the vast majority of the dementias are not, strongly inherited or genetic. We did talk a bit about the genetics of dementia in our previous live event. But whereas genetic causes are quite unusual, at least strongly inherited genetic causes are fairly unusual with some of the dementias in older adults. They probably make up at least 10% of those who are presenting with a younger age of onset. So many of the conditions you mentioned, like Huntington's or some of the other ones, are definitely ones where there should be a bit more of an index of suspicion of looking for a family history, looking for a genetic cause potentially, as well as ruling out any of those other conditions that may cause symptoms of dementia but be treatable.
Yeah, and there are, there are some kind of red flags that you'd look out for as well in terms of young onset associated with other conditions. So strong findings on your physical examination, you're much more likely, if it is one of these rare conditions, to pick up challenges with coordination. So people, normal finger to nose testing might look like this, and people have problems with their cerebellum will have challenges with coordination. People may have jerky movements or, have problems with their reflexes or not be able to move certain muscles, or have kind of not interesting, but abnormal movements just at baseline sitting there. So, there's a lot we can pick up on our physical examination and the history that can narrow down the set of conditions that we're looking at and cue us off to do further investigations, which we might not normally do in just a normal case.
One of the things that I've noticed in my clinical practice, while it may seem obvious or easy if there's a family history of Huntington's or another one of these genetic disorders, that family history is not always quite so clear cut. So in some of the conditions like Huntington's that may present with behavioral or personality or psychiatric symptoms, it may be that the people have some of the symptoms, but perhaps die at a young age. Often people have impulsive behavior or psychiatric syndromes. So they may actually die or lose touch with their family prior to the genetic or definite diagnosis being made. So often we are trying to get a family history, but there isn't necessarily a very clear family history of dementia with a positive genetic diagnosis. The history might include sort of gaps in it, like, oh, I didn't know my father, or, he died at a very young age or something like that. So, not all of these genetic causes of younger onset dementia are straightforward to make just on the history alone, but that is one of the things that caregivers and people living with cognitive impairments should expect when they are seen for a diagnostic assessment. When we're thinking about some of the causes, and you mentioned some of the same diseases, so Alzheimer's disease, which is the most common cause of dementia overall, it's also thought to be the most common cause of younger onset dementia. Is that right?
Yes, that's right. There are some case series where they do kind of larger studies where they'll follow people with symptoms and have neuropathology where they'll actually have people's brains. And in some of those series, frontotemporal lobar degeneration related conditions, so a behavioral variant amongst others, can approach Alzheimer's, but depends on the case series that you're looking at. And there might be a bit of a referral bias as well, in that at those centers, people are more likely to refer their behavioral variant cases, but definitely Alzheimer's disease is still the most common cause.
And I used to work in a clinic that would work with adults with intellectual disabilities, and one of we would see people with trisomy 21, also known as Down syndrome. People with Down syndrome, because of their extra chromosome 21, are at much increased risk of the development of Alzheimer's disease at a young age. So that is definitely one of the things to consider in a person living with Down syndrome who in their 30s or 40s experiences some changes in their thinking and memory. Alzheimer's disease is definitely more common in a younger onset in that population. In terms of people with, you mentioned the behavioral variant and frontotemporal dementias, vascular dementia is also thought to be one of the common causes there. We had a live event on vascular dementia. What would be some of the causes in a younger population? Would these be, we had talked about the potential after a large stroke, somebody might develop dementia, but then there's also people who might have a series of smaller strokes with small blood vessels. Is it the same picture in younger onset dementia due to vascular causes?
Yeah, I think it's more likely to be related to larger strokes, like lacunar infarcts in people's brains that are 50 and 60 are a lot less common. So definitely in that sense. And I mean, I mentioned CADASIL. It's a very rare condition, so you don't see that very often. So a slight change to people that are having the larger strokes, which does happen less commonly in younger adults. Perhaps they had a heart rhythm problem that made them prone to stroke, or they have a blood clotting disorder, which increase their likelihood of having blood clots and strokes earlier on in their lives. And then there are people just unfortunately will have a stroke at a young age. It's just a decreased probability or proportion.
The one other cause that I think we should do a future live event on the topic, but the one other related thing that I would say you and I see in the hospital setting is alcohol-related dementia. And, here the scenario might be somebody at a younger age who has generally moderate to severe alcohol use disorder. And that puts them at risk for a condition we call Wernicke-Korsakoff, which is a consequence of the vitamin B1 or thiamine deficiency. And that syndrome of the Wernicke side of it is when we see people generally with severe alcohol use who are very confused. They have an eye muscle problem, so that their gaze does not follow, their eyes do not move conjugately, so they often have sort of double vision, and then their walking is incredibly unsteady and they may be falling. So that's the Wernicke syndrome, which, if it's recognized immediately and treated with thiamine supplementation, can be reversed. Unfortunately, if it's not recognized early enough or treated promptly and with the right doses of thiamine, it can then go on to develop a permanent type of amnesia where people cannot form new memories. And as you can imagine, the functional impairment related to that type of memory issue, it becomes a huge issue for people. And I would say the prevalence of Wernicke-Korsakoff is probably underestimated when you look at studies. People with alcohol use disorder in particular have high rates of this. And I think the functional impact of alcohol, long-term alcohol use, there are other toxic effects of alcohol on the brain that lead people with years of alcohol use disorder to develop dementia. And I would say that's probably another maybe less well documented cause of young onset dementia.
Yeah, absolutely. And I mean, it's funny because I think we learn a lot. We learn a lot about Wernicke's and Korsakoff's in medical training, and it's still under recognized or potentially undertreated in terms of the actual thiamine dosing used, sometimes too little. But then also just the direct toxic effects of alcohol on the white matter and the atrophy or shrinkage that can occur related to that. And, there's the low level of thiamine, which is associated with decreased consumption, but then there's impaired functional use. So even if you're taking alcohol and your thiamine levels are normal at the level of the cells, you can't use the thiamine appropriately. And then, you mentioned if you're having falls because you're intoxicated or because your nerves don't work because alcohol's caused damage there, or your cerebellum doesn't work, and then you have head trauma on top of that and concussions, then that's problematic.
Yeah, that's another risk factor for dementia. Yeah.
And then the liver disease. I think we've talked about that too. If you have cirrhosis or develop cirrhosis, that can cause hepatic encephalopathy as well. So there's all these convergent kind of areas. And it definitely, we do see younger people with these problems in hospital and outside of hospital quite frequently.
Yeah.
And the one thing I'd say about the alcohol too is I find it interesting that even if alcohol is one of those causes that are reversible, even if the person's not acutely intoxicated while you're testing them. So I've seen people, when they get appropriate treatment for their alcohol use disorder, actually improve their cognitive scoring remarkably. They didn't have Wernicke's-Korsakoff's, they just had an alcohol-related cognitive impairment. But when they're able to abstain, they improve substantially with respect to function and cognition. So that's always an interesting one. And sometimes that takes 3 to 6 months for it to occur. So I'm always hopeful when I see people with that condition.
I would say that's true of some of the other substance-induced cognitive impairments, that if they're caught at a certain time, depending on the substance, they may be totally or substantially reversible. So maybe another live event topic, I think, is a really important one. Why don't we get to some of the questions that are coming in, and we'll see where that takes us. So here's a question. Is Alzheimer and dementia brought on because of a lack of certain vitamins and or minerals? Well, I guess there are some vitamin deficiencies that are important potential causes of cognitive impairment that can look like dementia. So we just talked a little bit about thiamine deficiency. People with severe vitamin B12 deficiency may present with cognitive impairments. Lots of minerals, actually, if you have changes in your calcium, too much or too little. So these are conditions which we think of as potentially leading to cognitive impairments that might look like dementia. Sometimes they are called reversible causes of dementia if they're recognized and treated soon enough, but they may go on to become irreversible if they're not recognized or treated. At this time, we don't think of Alzheimer's disease being caused by a particular vitamin or mineral deficiency, but with any of the dementias of another cause like Alzheimer, you may also have other related vitamin or mineral issues that should be identified and corrected because it might be associated with cognitive or other changes. Any other comments to add about that?
No, that's a great synopsis.
Is cognitive impairment caused by stroke considered a form of dementia or would lead to dementia?
Yes. So there's a form of vascular dementia, which is, a single infarct or single stroke, and somebody has cognitive impairment and functional impairment. Some people would refer to that as a post-stroke dementia. But there's the vascular component there. So that's one of the various types of vascular dementia. Sometimes people will have multiple strokes, and so you'll see a stepwise decline. We've discussed this before. And other times people will have the small blood vessel disease in the subcortical region of the brain, so underneath the outside white matter, which will result in it. So this is one form of vascular dementia, if you can attribute the cognitive impairment to that stroke and functional decline.
And I think our lesson on the types of dementia has a section on vascular dementia, and our recent live event is probably if you're interested in learning more about vascular dementia. And I think it's just a good reminder for us that dementia is an umbrella term which can have multiple different causes such as Alzheimer disease or vascular dementia or others. So, can dementia be caused by pressure on the brain from a tumor?
Well, cognitive can certainly result in cognitive impairment, but that would not be one of the causes we can consider a dementia in that situation, which is generally a slower progressive decline related to a neurodegenerative protein problem or a vascular event. It would be just cognitive issues related to an acute medical illness, which is a malignancy or cancer. So the cognitive problems related to that are not considered a dementia.
Yeah, and I think maybe it's some of the terminology is helpful in that way. We can see cognitive impairments in a wide range of different conditions, some of which may be reversible, some of which may not be reversible. And cognitive impairment is one of the hallmark signs of a dementia. So I think that's maybe, we think of pressure on the brain from a cause like a tumor as leading to cognitive impairments. And I think when you're looking for a diagnosis, people don't necessarily know what is causing their symptoms. So they don't necessarily, go to see a healthcare provider saying, can you check out my dementia? They would go and say, I'm having these types of symptoms, or my care provider is seeing these signs. I'm having problems with memory or language, or my personality has changed. So these types of cognitive changes might be noticed. And then the role of the physician or the healthcare team is to try to provide an accurate diagnosis. It might be caused by a dementia, or it might be caused by a tumor that's causing pressure on the brain, or it might be caused by some other kind of illness like an infection. So the general symptom or some of the signs may be different types of cognitive impairments. There may be one of the causes of dementia, or the syndrome of dementia, due to a particular cause might be the relevant diagnosis, or it might be something like a brain tumor. Can you please talk about Alzheimer mixed with vascular dementia?
Sure. So we've talked about how people with Alzheimer disease will present with respect to short-term memory problems, visuospatial problems, language issues, and sometimes praxis, which is the learned coordination of motor function. So brushing your teeth or brushing your hair, people will complain of clumsiness. And the most common forms of vascular dementia would be more related to executive function, so planning and organizing, multitasking and sequencing and things like that. There are some cases, though, where somebody will have classic Alzheimer presentation and have significant testing abnormalities, which are consistent with an Alzheimer disease, but also when you look at their imaging, have quite a significant vascular burden. So you can actually see small or large strokes in important parts of the brain, or there's quite a lot of that small blood vessel disease. And in situations like that, you've got a bit of a mixed picture, both on the symptoms that people present with, as well as sometimes the physical exam, and then the imaging that people look at. So there are situations where it's not clear. There are cases as well where you'll post-mortem or after death, you'll do an autopsy and you'll find Alzheimer's disease mixed with Lewy bodies. So that's a different form of a mixed pathology dementia. Sometimes it's hard to pick out how much of each was contributing. It's almost impossible to do, but it's never, or frequently it's not a completely one pathology related story.
It's worth highlighting that in the vast majority of cases, and I mean vast majority, the diagnosis is a clinical diagnosis. In other words, we rarely would have a blood test or a genetic test that will say definitively you have this type of dementia. So as Richard mentioned, sometimes there are cases where it's diagnosed at autopsy or part of a research study where, a clinic might follow a series of patients, give them a diagnosis clinically, and then after death, investigate to see if it can be confirmed. In some cases, there might be a definitive diagnosis, certain conditions like Creutzfeldt-Jakob prion type of disease, or Huntington's with a definite genetic diagnosis. But most of the time, we're going on the clinical history, a physical exam, and some lab investigations or brain imaging. And so there might be, based on all of those factors taken together, you might say, geez, I think this is a mix of Alzheimer's disease and vascular dementia, but it's not as definitive as, having a blood test that says that's what you have. So on that note, we have a couple of really good questions, I think, related to diagnosis. So one of them is, what tests/procedures allow for an official diagnosis of dementia? And I would just merge that a little bit with, how does that differ, or is it similar or different in a young onset dementia context?
The diagnostic process is an interesting one where not frequently do you have absolute certainty. You're always shifting probability from more likely to less likely. So what you're looking for is a consistent story based on the history, or how somebody comes and tells you what their experiences are, a physical examination, some cognitive testing or neuropsychologic testing, which are the kind of pen and paper tests that we put people through, blood work, and pictures of the brain. So, that whole process, you're looking to have a consistent story, and physical examination and imaging and blood work kind of all line up with one another. So aside from the history, the important things are getting blood work to make sure there's no other causes of the cognitive impairment, like an inflammatory condition or a vitamin deficiency. And then the imaging itself can narrow it down, because it can find a stroke for you in a specific area, or it can also see whether there's been significant shrinkage or atrophy in the brain. And in certain dementias, you'll see very specific parts of the brain get smaller than all of the rest of the brain, which stays intact. And those patterns of shrinkage can also point you in the right direction. There are research tests that we've mentioned before where you can actually tag the proteins and cause them to light up on PET scanning. But those are just used for research right now. So those can increase the specificity, but they're not widely in use right now because they're quite complicated to put together. But all of those tests are important. And then if there are more red flags, so generally the scan we would get would be an MRI of the brain. But if there are other kind of red flags we mentioned, abnormal movements or rapid progression, then we consider getting additional tests. So like a spinal tap, where we put a needle in somebody's back and there's fluid that bathes the brain and the spinal cord, and we can sample that. And generally, if there was an infectious condition or an inflammatory condition, we'd see white blood cells at an elevated level or abnormal protein levels in and around that space. And we can also test to see if we can grow bugs or infections. So I see one of the additional questions is, is Lyme disease a contributing factor to dementia? So we can test if there's an indication that there's some sort of infection. We can actually test and see if we can grow various viruses or bugs, or see if there's inflammation there. And then find an additional test would be an EEG, where you can look at the electrical mapping of the brain and see what the various patterns are there. So you can see that, there's our baseline testing. And if there are additional kind of red flags that cue us off to things, we can do a whole next level of testing which can be quite a lot.
Yeah, and sometimes those special tests, somebody might be referred to a center, like an academic health science center for special investigations. I was going to follow up with some other things, but there's a really a helpful story or comment from somebody that just came through. So it took my doctors 8 years to diagnose my young onset dementia. My journey began when I was 51. Today I'm 64, and I recently found out I have vascular dementia. I believe that doctors are hesitant to give a diagnosis of young onset dementia. Do you think 14 years is typical? And I would say this story actually encompasses some of what I saw in the clinical settings where I worked in, a sort of neuromuscular, neurogenetic, neurometabolic clinic where people did often have more rare disorders and had gone through a pretty long and sometimes frustrating diagnostic journey. So I don't know that I could put a number on it as like is 14 years typical, but I think it can often take many years to get a diagnosis in some cases, especially a more definitive one. I think your comment about many doctors perhaps being hesitant to give a diagnosis of young onset dementia, I think many doctors are hesitant to give a diagnosis of dementia generally. So I think there's evidence that dementia is underdiagnosed. And part of that may relate to index of suspicion. So again, one of the challenges I think with that people who are younger at age of onset is physicians may be not just reluctant to label it as young onset dementia, they may just ascribe it to something else because they're less used to seeing people with dementia at a younger age. So they may think it might be stress related, or it could be, something else. Maybe they're worked up or referred somewhere, but maybe it's the symptoms kind of minimized because they're not thinking about it at all. But then I think there are also factors related to probably stigma or not really sure what to offer patients once they do provide a diagnosis. In the literature and in Canada, talking about young onset dementia, it's definitely been identified that there are a lot of gaps in services, and that includes, I think, getting a diagnosis early, as well as the services. And I think you described really well, Rich, that often there isn't the right cohort. Caregivers might have different issues. The people living with dementia may have different issues than people who are 20 or 30 years older who aren't necessarily still working. So yeah, I think lots of disorders that can cause young onset dementia, some of them more rare that some physicians may be less aware of or aren't sure how to test for. The overall principles around diagnosis are comparable, although there may be more special tests involved if you do suspect a movement disorder. But I think the index of suspicion for many physicians is lower. So there's probably even more underdiagnosis in a younger population. Any comments on that, Rich?
I think you made some great points. One thing I like to bring up with residents, like medical trainees that are coming through, when I give them the opportunity to try and disclose a diagnosis of dementia, they're actually quite awkward about it to begin with. And I think that has something to do with the stigma issue that we've discussed in the past, and the comfort level that you're talking about. They just don't see it as frequently. They're not exposed to it as much. There aren't that many cognitive specialists and cognitive behavioral neurology teaching that most of the trainees get. So there's this lack of comfort, I think, amongst medical trainees, but also many physicians in practice. And then to your point, I mean, most times I'm sure family physicians will see so many people present with cognitive fuzziness or not really feeling like themselves. And, the more common diagnoses that they will see and treat successfully will be a sleep disorder or depression or a hormonal problem. So I think that's a bit of the kind of recency bias that people have. And if you see and treat people all the time and it results in positive results for that patient, then it just confirms what you're seeing. And then when something's slightly out of character, I think that's the important thing, is to have the cognitive flexibility to switch and say, well, there's not a sleep or a mood problem or a hormonal imbalance here. I need to get them to see somebody else. And so I'm not sure what happened with this patient, but maybe that's what they were thinking. Now, yeah. 14 years is obviously quite a long time to wait for that diagnosis. And if you have persistent cognitive problems, you should get an MRI. So, and that could fairly easily pick up on the vascular disease that could have caused this. So definitely typical for young onset dementia people to have this delay for all of the reasons that we're talking about. And the other challenge is, rare disorders are rare. Like, you'll read about them in textbooks, and then you're expected to diagnose them based on kind of, your clinical, index of suspicion. But they're also sometimes just hard to diagnose, even if you have very capable physicians that are thinking about things, because you cannot order every test for every person. It's just not possible.
Do you have about 5 more minutes that you can stay, Richard? So I just wanted to read another story that came in. This is a woman who has a daughter who's 61 and a younger sister who's 60 who has been diagnosed with young onset Alzheimer's. The one daughter who's 61 is a personal caregiver now and living there, and they're all sort of working together as a family as best as possible around this caregiving situation. She says, being bored with the pandemic, they started an educational but also very personal site on TikTok to discuss what it's like for them, the sister caring. And many other caregivers have contacted them, told them it's very helpful. So their site is called the Kathy Project, Kathy with a K, so Kathy, the Kathy Project on TikTok for a caregiver for her sister who has young onset Alzheimer's. So I just wanted to share that.
Yeah.
A couple of other things before we wrap up, though. One of the questions, or two relative questions. One is, if there's no cure, why bother with the diagnosis, is one of the questions. And then, how important is it to get a diagnosis of what type of dementia you have? Yeah.
Well, if there's no cure, why bother with the diagnosis? That's important. So, I talk about other medical conditions when people will bring this up. So let's say heart failure. People treat it as a very serious condition, and there's lots of scientific study being done in the realm. And when people are diagnosed with heart failure, they'll be accepted of it and receive the treatments for it. And there's symptomatic treatment and benefit. And you can also understand why things are happening to you and why you're experiencing the symptoms you are, and what the overall prognosis or the course of your illness is expected to be, because that's very helpful for planning out your life. And I don't see dementia as any different than that, in that there are very specific symptoms and management strategies, both medical strategies and functional help and supports, that are very effective at treating both the patient as well as alleviating the stress of caregivers. So we can make your life a lot better. In order to do that, we need to be specific about the diagnosis in terms of, why are you having this cognitive impairment, and what are we going to expect in the future? And then understanding the differences between the diagnoses. So, there's many different reasons, but, one example is the people with dementia with Lewy bodies or Parkinson's disease dementia can have really, they're called sensitivity reactions to certain medications, neuroleptic sensitivity reactions, where people can get very, very sick if they're given high doses or too many doses of these medications. And if you didn't come up with that specific diagnosis, you wouldn't know to avoid those medications in those people, which can have disastrous effects. So, and all you have to do is you'll chat with families that have gone to several different physicians, and Parkinson's disease and Parkinson's plus syndrome is a good example. They get confused. They're given 2 or 3 diagnoses, and they're like, well, they go and read every bad thing about every diagnosis. You have a Parkinson's plus disorder. Well, if I can tell them very specifically, like, you most likely have, corticobasilar syndrome. We're not 100% on the diagnosis, then people aren't overwhelmed with the same amount of information, and they feel like they, have some guiding principles to what's happening to them. So I think
it's a great summary. There's also, I would say, for many people, even if there's no cure, there are psychological advantages and a bit of relief from kind of knowing what it is. In some cases, obviously, there may also be genetic implications for their family members, but we have lots of conditions in medicine where we don't have a cure, but knowing what it is can help you to manage the condition better or worse, avoiding things that might make it worse, trying to do things to promote it. If you know you have a vascular dementia, hey, see what you can do about managing your blood vessel health to reduce it worsening. So, but I wouldn't want to underestimate the psychological advantages, having seen many patients go through, long diagnostic journeys, to sort of at least know, hey, I wasn't going crazy. I didn't have nothing. Sometimes there can even be insurance implications for, having in a positive way or service access. It's like, oh, I can't access such and such a service because I don't have a diagnosis of dementia. But once you do, so there are absolutely things that are beneficial for knowing the diagnosis. I just want to end with one other final sort of statement, but it also ties in, I think, with a young onset before we wrap up. This is a comment that says, I've spoken to 4 different neurologists before I got my diagnosis. My dementia led to my leaving my profession. Can you comment on the financial effects of not being able to work? And then also, I had many MRIs during that 14 years. Each doctor knew I'd had a brain bleed and 3 TIAs. It seems to me that they could have had quicker results. But I think this is a really good comment. We did allude to it, but with young onset dementia, people may be more likely to be actively working rather than retired. They may have a lot of financial obligations like mortgages or dependents that are relying on them. So I think there's psychological effects of not being able to work. And of course, not everybody who is diagnosed with a young onset dementia necessarily has to stop work right away. Depends on their job and their stage and the symptoms they're having. But I think there are, obviously both psychological and financial implications. And another reason I think for having an early diagnosis is to enable planning and financial planning as much as possible, though the implications may still be very challenging if there's lost income for many years. So, any thoughts from your perspective, Rich?
The only additional item that I would flag is just the Canadian disability tax credit, which a lot of people don't apply for. So there are forms online that you can print out, and if you're required to give so many hours of care and you have a diagnosis that's impacted your ability to function, then you can get quite a substantial tax credit. And if it's taken place over the past, 1 to 2, 3, 4 years, you can apply for it retrospectively as well. So from a financial point of view, that could be helpful depending on what your set of circumstances in. But I agree totally with everything else you just said.
And I think, there's some good information on young onset dementia on the Alzheimer Society of Canada site. They highlight 2016 work that was looking at information and service gaps specifically for people with young onset dementia and their care partners. And I believe there are steps that are being taken as part of that analysis of the information and service gaps to try to improve the landscape for people living with young onset dementia and their care partners. So I want to thank Dr. Stramko, as usual, for a great live event. iGeriCare was developed with support from a number of our friends. The Center for Aging and Brain Health Innovation, or CABI, powered by Baycrest, the Jerris Center at Hamilton Health Sciences, the McMaster University, the Hamilton Health Sciences Foundation, the Alzheimer's Society Foundation of Hamilton Halton, and our Division of E-Learning Innovation team has been great. Just a reminder that our grant applications and then donations really keep iGeriCare going. We've been really grateful for the donations. Please keep it coming on our website, iGeriCare.ca. The donate button is in the top right. 100% of your donation comes directly to our team to continue to produce the live events, continue updating multimedia lessons. We recently added a review lesson on the lessons page if you're interested. We've also recently been working on a version of our lessons that's targeted towards personal support workers and unpaid care companions. So if you are one of the healthcare providers who finds our live events interesting, you may look out in September or October. In the fall, we'll be launching an online course with a certificate for PSWs and others to improve their knowledge of dementia. There's a survey as well pinned at the top of the comments section. You can always send us your input and feedback as well through email as well. But we always look to your interest in what you're looking for next. And the next live event is scheduled for Thursday, September 16th, same bat time, same bat channel. And once again, thanks to the whole team and Dr. Stramko. As always, teamwork makes the dream work. So we'll see you in September.